I remember that.
We used to use saran wrap. The baby would be there with all the tubes, and they would literally put saran wrap over it to keep it warm, to keep the wind
Yeah, they
down.
had the big thing of saran wrap, and they would tear it off and wrap the baby in it.
Welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is Dr. Michelle Merrihew. Welcome to the show, Michelle.
Thank you for having me.
Michelle is a dear friend. She's a colleague here with me at Boone Hospital Center. Michelle is a neonatologist, which means she's board certified in both pediatrics and neonatal perinatal medicine. It's a lot of training, Michelle.
That is.
Many years.
Yeah, so we do a 6-year pediatric residency, and then we do, or 3-year pediatric residency, and a 3-year neonatal fellowship. So a total of 6 years.
6 years after medical school. So you're a doctor, but you're not yet a doctor.
Nope. It takes a long time to learn to do what we do. And I always tell parents that in my prenatal consults. I'll go through all the details of potential things that can happen with their babies. And they are staring at me kind of blankly like, wow, that was a lot. And I say, well, it took us 10 years to learn it, and I don't expect you to know it in 10 minutes.
Right. So when did you know you wanted to be a neonatologist? Did you want to be that all the way through medical school, or did you want to be a pediatrician and got drawn to the neonatal intensive care unit called the NICU? When did that happen for you?
So I actually took a slightly different route. I went to medical school, and just to kind of go back, I was a history major and decided after I graduated with my history degree that I wanted to become a doctor. And so I did all my pre-med stuff as a post-baccalaureate. Then I went to medical school, and I really enjoyed pediatrics. So I did my pediatric residency. And when I first finished my residency, I really actually wasn't sure exactly what fellowship training I wanted to do. And so I took a job working in the NICU at Children's Mercy at night.
In Kansas City. So you had finished residency in pediatrics.
That's correct.
And you started moonlighting at night in the NICU.
That's correct.
And did the bug bite you?
It did. And so I decided to go back and do my fellowship in neonatology because I absolutely loved it. And I'd gotten to the point where after about a year of doing that at night, I thought, okay, if I'm not going to do NICU, I'll lose my general pediatric skills if I keep doing this, but I enjoy it too much. So that's when I decided to do the neonatal perinatal fellowship, which we call it just NICU fellowship or neonatal fellowship. Mm-hmm.
Gotcha. My last baby I delivered was in 1994. I was moonlighting as an obstetrician. I was also doing my fellowship in infertility and reproductive endocrinology, and to make a little money. We're very poor. I delivered babies at night. Usually the inner city, that's where they needed us. And people may not realize that the obstetricians and the neonatologists spend a lot of time together at deliveries, because if there's a delivery where we know there's going to be a problem, or it's sudden onset premature delivery and whatnot, we call neonatology, call the PD team. Mm-hmm. So usually in the middle of the night, your ilk and my ilk are together as a team, because the woman delivers, we're taking care of her, the baby passes off to you, and you're humming at the incubator. They still call those warm tables
radiant warmers.
Radiant warmers. Do they call them Ohios anymore?
No.
We called them Ohios. I guess that was the brand that they used at the time. Have you heard that before?
I have never heard that term before.
We call them Ohios in New Jersey. And so your team's working and our team is working frequently at C-sections. You'll be there. So it's quite a hive of activity, and we work together usually quite a lot. Now,
so we don't really train together, and we have very different professions.
Right.
And every now and then I'll have a mother ask me a question, when will I come off the magnesium, or when will I do this? And I say, well, I haven't done adult medicine for years. As a matter of fact, the last time I did it was the Heimlich maneuver in the airport. 10 years ago.
So we stay in our lanes, dude.
Yeah, we stay in our lanes. But we do interact a lot with the OBs.
Yeah.
I actually also delivered a baby about 3 years ago before the OB wasn't in the room. So I ended up catching the baby.
Paging any doctor, stat.
Well, I happened to be standing at the radiant warmer and the baby just started coming out. And I was there and I said, well, I've done this before in medical school. So I stepped in. And
You had some gloves on.
I
and
had
put
some
on
gloves
some gloves
on.
and boom, there you were.
Yeah.
Wow. So in the NICU, Michelle, you all do amazing things. I'll never forget as a medical student, some things hit me. One was the first time I was in the intensive care unit. Most people are older and and I found that very poignant and difficult at first to get used to older, essentially dying people. And I had a very similar experience in the NICU because we frequently had these very premature babies, little infants. And I'll never forget the neonatologist calling it the patient. And it took a real mind. Of course, it's your patient when you think of it, but when I first heard that, to consider this little beautiful little being that can't talk, to consider that a patient was just a I'll never forget. Realize, oh yes, that is a patient, and you do incredible work. Now in the NICU, much of your work is around premature infants. Isn't that correct?
That's correct.
And you will take care. Let's say you have a full-term baby that has a heart problem or some other serious problem. You also take care of them. So it's not exclusively premature, but
That's
a
correct.
lot of them are, aren't they?
Yes. So the majority of babies that we take care of are actually late preterm babies. And so those are babies born between 34 and 37 weeks gestational age. And a good majority of them come to us for problems with feeding and low blood sugars.
Now just so people understand, a full-term pregnancy is 40 weeks. We're 280 days from the first day of the last menstrual period, if you want to get super precise. And we call full-term anything after 38 weeks. Or full-term, I think, is technically 37 weeks. But most women, we want to deliver somewhere around 40, between 38 and 41 weeks. Just so people understand what the weeks mean. We don't go by months. Months are not precise enough.
I don't know exactly how the months work either anymore. It's all about the weeks. And
yeah, it's 280 days. So how do you divide that into months? So do a lot of stuff, Michelle. It used to, now most babies come out around, 7-8 pounds, which is roughly 2.5 kilos or 2,500 kilograms. And when a little baby is born prematurely, one of the most important assessments is how much does it weigh. And I remember delivering a severely premature baby. It was coming. It was the inner city. It was a poor inner city girl and teenager. And here comes this tiny little infant. You try to deliver it with as little trauma as possible. And I'll never forget them putting it on the scale. And it was 525 grams. And 500 was the cutoff back then. And so full code. Got all the care they could provide. Now, I have a little nephew who was at the time close to the world record. I guess 25 years ago, the world record was something like 22 and a half weeks. They had just gotten under 23 weeks. Tell me if I'm wrong, but I just Googled this so I'd sound smart with you. And I believe the world record, at least as of 2020, was, I wrote it down somewhere. I think the world record was down in Alabama. And the world record was 21 weeks and 1 day with a little infant that weighed 420 grams. Does that sound about right?
That does.
That's close.
I mean, that might be the world record, but it's also possible that maybe the baby was a little bit older. Because the success rates below 22 weeks, there just isn't
virtually zero. Yeah, virtually zero. So I remember that little premature infant coming out. If it had been under 500 grams at the time, it's a zero survival, and you make it comfortable because you can't do it.
So the biggest problem we deal with small babies when we're getting into the extremes of prematurity is lung development, because depending on the amount of alveoli they have, which are the little air sacs that allow us
at the end, so the air goes down, it gets smaller and smaller, branches and branches and branches. Correct. And in you and me, it ends in a sac called an alveolus or an alveoli. So those don't even develop. Those aren't even developed until 28 weeks, right?
Well, the alveolar stage of development starts, but actually we can see alveoli begin to develop between 22 and 24 weeks of gestation. So there are some air sacs present, which allows us to resuscitate babies that young. However, it's unpredictable how many they actually have and if they have enough lung tissue that is compatible with life. In the future, we will hopefully have liquid lungs that will allow us to do more.
That's something that is fascinating. When a baby is developing in the womb, it is underwater. It's an amniotic fluid, and it's breathing. And then when it's doing breathing, it's breathing fluid, isn't it?
That's correct. And that is physiologic. Parents are often told it's practice breathing, but it's actually physiologic because it allows them to stretch those alveoli and stretch their chest cavity, which promotes development. And I always remind people that breathing in utero is limited, and so it's inhibited. And when your baby's born preterm, we often have to treat them with caffeine because we have to overcome that inhibition so the baby can continue to breathe continuously.
So caffeine is a common medicine, a common drug, huh?
Mm-hmm. Our drugs in the NICU are very simple, and caffeine is one of them. And not only has it been shown to not be harmful, it has been shown to have potentially improved neurodevelopmental outcomes in our very preterm and preterm infants.
Wow.
And so we give it to them because it blocks the inhibition, which is responsible for causing the apnea of prematurity and the bradycardia desaturations. Right. And so they can
apnea means they don't breathe, and bradycardia means a slow heartbeat.
Mm-hmm. And that's all a result of the central inhibition to breathe and the increased vagal responses that preterm babies have.
Then the vagus nerve goes from the brain. It's the last cranial nerve. It goes down to the gut and the body itself, mm-hmm. and it's responsible for a whole host of what are called parasympathetic functions, which include digestion and regulating the heartbeat. That's amazing. So, Michelle, I've thought, how are we going to describe this? How are we going to have this conversation in just an hour? You spend your life doing this, and how can we do this? So I thought maybe we'll walk through what a parent or parents can expect if, God forbid, they need special care for the infant. So let's go along a case scenario. A woman is pregnant, mm-hmm. she's healthy, everything's going along fine. She's had her baby shower, no problem, all the ultrasounds are normal. Now she starts to go into premature labor, let's say before 37 weeks. Mm-hmm. But she's getting near, but now she's in premature labor, and obstetrician realizes this, and we frequently give, when I was an obstetrician, or my colleagues will give some shots of things called steroids, called glucocorticoids that may speed up lung development, mm-hmm. give the infant the best shot. So the infant's born a little premature, and the obstetrician says, hey, we're at 36 weeks here, ma'am. We need to have the the PD team here. So in comes Dr. Merrihew with your nurses and your team. Let's say infant is born, goes on the radiant warmer, having a little trouble breathing as expected. What are you going to do for a baby? Now, what would you call that? Near preterm? What would you call that?
Late preterm.
Late preterm.
So the late preterm period is anywhere between 34 and 37 weeks. Okay. And I always tell parents it's frustrating because you're so close, but you're just not quite there. And there are so many things that happen at the very tail end of pregnancy. And one of those is that the lung begins to produce surfactant. And surfactant is a fatty substance that coats all of our lung lining. So it's produced in the alveoli. And at this stage of development, all of these babies have lots of lung tissue. It just isn't always producing the surfactant. Now,
kind of soapy
the
stuff.
soapy
it's
stuff.
foamy, and that lowers the surface tension so that the lungs can expand better, I guess.
Expand easier and maintain what we call functional residual capacity, which just means keep the air sacs open. Because right now, you and I are sitting here breathing, and our air sacs are open. They don't collapse on themselves. And so after birth, when the baby cries, it forces the fluid out of the lungs. And because there's plenty of surfactant there, then the baby can breathe easy. And so it's similar to when you blow up a balloon. The first time you blow, you have to take a big, hard breath and break that surface tension.
Okay.
And surfactant then maintains it. So then the baby can take small breaths, just the same as you would when you're blowing up that balloon. One big breath.
Yeah, that first one's tough, and then once you get going, it's easier.
It's easier, and then the baby can breathe nice and easy.
Wow.
And so oftentimes what happens in these late preterm babies, even if the mother has gotten steroids, the lungs can't produce the amount of surfactant, or there's too much fluid in there, or the baby airway-wise isn't quite able to maintain that, what we call the functional residual capacity, which is just keep the airway open.
Okay.
We have to put a breathing tube in them, and then we deliver surfactant that's made exogenously.
So they can make it. Is it made like in a lab synthetically, like the chemists make it?
And it's actually derived from bovine surfactant.
You get it from cows, so it's a cow. It's a purified cow.
Yeah,
surfactant.
it can come from cows, pigs, and then there is a form of synthetic surfactant.
Okay.
And what we do is we deliver it into the lung, and the baby takes it up, and it actually works best if we give it in the first few hours of life. And that is totally based on the clinical appearance of the baby. So
let's say the baby's in the radiant warmer having trouble breathing. Don't want the parents to be startled, but you might intubate. You might put a tube through the mouth into the trachea, into the lungs, and then you'll squish in a syringe of surfactant, and then hook them up to a little machine to help them breathe. And also, there's something called an ambu bag, isn't there?
We'll bag it in there.
You bag it, so you've got a squeezy bag, and you use that to breathe for the infant and open up the lungs and give them a positive pressure.
Yes, and they may spend a day on the ventilator. There are many different clinical scenarios, and there is not a one-size-fits-all. Some babies, especially in the late preterm, will need it immediately in the delivery room. Some babies will come out and need it at a couple hours of life, and I have even had to give it up to 3 days of life. We try to avoid in late preterm babies as best we can putting that breathing tube in and giving that medication, just because there are some risk benefits, and so many of them will eventually work through this lung disease. But when we have to give it, we have to give it, and how long they'll be on the ventilator after that just depends on how long it takes to distribute. And then the body actually takes up that synthetics, or not synthetic, but medical surfactant, uses it, recycles it to start making their own surfactant. And surfactant production will actually kick in between 3 to 4 days of life naturally after the baby's been born.
So if they're late preterm, I used the wrong term there.
And we emphasize late preterm,
right?
Because we want people to understand when they've had a baby before 37 weeks, their baby is a preterm baby and will have those struggles. And
yeah, it could have the struggle, and that's why having him in the hospital and having you around to observe, say in case it starts to deteriorate, there you are to save the day and intubate them and get them over the hump.
That's correct. And it's not a written in stone rule, but as a general rule, babies born less than 35 weeks, so in the 34th week of pregnancy, are automatic admissions to the NICU. Babies born over 35 weeks, if they're doing well clinically, we will keep them out in the well nursery or the typical newborn nursery, but they have to be breathing good, be able to take enough feeds, and maintain their blood sugars. And we'll keep them a little longer in the hospital to make sure they're not losing weight. And so there is a gestational cutoff for when a baby definitely has to come to the NICU.
I see. I'm going to say something else. As an obstetrician, when we help women get pregnant, we send them on to their dedicated obstetrician. I am obsessive about giving a very precise due date. Generally, we know exactly when conception occurred, and we can nail it in stone. Mrs. Smith, your due date is December 12th, for example, and that's it. Nobody can change that. Now, these women in my clinic have the advantage. We know when they ovulated. We know when we transferred the embryo. But someone out in the real world, is particularly a woman with irregular periods, or they come every few months, doesn't necessarily know when she got pregnant. So you don't necessarily know if she's full term or not. And sometimes a woman can be premature. She thinks it's 40 weeks, but it's 30 is less, right? And can run into prematurity that was unrecognized. So getting this date, getting a good due date is really important. So I'm putting a plug in for that. So now we have a woman. Now she's delivering. When did you say before 35 weeks? Is that the next cutoff?
That's a cutoff.
So what week range are we talking about now? 34 to 35, 33 to 35, something? Do you have ranges?
So anybody born in the 34th week of pregnancy, whether it's 34 and 6 below, has to come directly to the NICU. We tend to look at the late preterm group between 34 and 37 weeks as late preterms because they typically have more trouble with feeding and blood sugars. And we also look at them in terms of long-term neurodevelopmental outcomes. Babies born before 34 weeks, between 32 and 34 weeks, have similar neurodevelopmental outcomes, and that just has to do with how the studies have been done.
And neurodevelopmental, that's the functioning of the brain and whatnot. So now you have an infant born 32 to 34 weeks. I assume it gets a lot more complicated. So obviously you have to breathe and have an airway. And in fact, even in adults, when there's a code, when somebody falls down, and we have A, B, C. Do we have an airway? Are they breathing? And do we have circulation? So I assume it's true with...
Same thing.
With everyone.
And in neonates, airway is always more important because ventilation is the key for circulation in our population. So where in adult medicine, circulation is more emphasized, in neonates, it's all about ventilating the babies adequately because that's how we perform our neonatal resuscitation. So good ventilation is essential for our babies.
So do we have a baby that's now what would be the term for 32 to 34 weeks? Just preterm?
Preterm.
All right, so now we have a preterm infant. It's going to get a lot more complicated for you, Michelle. What type of stuff do you evaluate at that time?
So at babies born in the 32nd week of life and between 32nd and 34 weeks, they are clearly preterm. They're no longer in that late preterm phase. So they're more likely to have breathing problems. They're more likely to potentially need surfactant or need a ventilator. They have a potential, depending on what brought them into the world, because there are multiple things that can bring preterm babies into the world.
Right.
They have higher risk factors for something called necrotizing enterocolitis. Although it's relatively low, they do have a little bit more of a risk factor because they were born preterm.
All right, so let's talk about the bowel. Babies are not only breathing fluid, they're swallowing fluid during their development. That fluid goes through the gastrointestinal tract as it's developing. And I don't know how much digestion is occurring, but obviously the muscles are starting to work. And something that people may not appreciate is that the immune system, lymph tissue, white blood cells are also developing in the bowel, or what we call the guts.
That's correct.
So if they're born early and they're no longer getting sustenance from the umbilical cord, they have to get it from somewhere. Now, can you supply much of that sustenance intravenously, or do you have to start trying to use the bowel too? That sounds like a difficult decision.
Yes. So our preference is always to start to use the bowel. We bridge that with TPN, or total parental nutrition, which is nutrition that goes through an IV. But the most nutritious thing for any preterm baby is to be fed, because they will absorb it better and they will gain more weight if they are being fed enterally. and weight gain is essential. I always say you'll outgrow all your NICU problems. And so getting the babies to gain weight is the most important thing we do. So going back in time, we have feeding protocols depending on what gestational age you're born at. And so if you're born at the extremes of prematurity, we're going to be a little more gentle with your gut. If you're born later in prematurity, we won't be quite as gentle. We'll go a little faster. And the goal is to get you up on full feeds as soon as possible.
And can the mother use her breast milk at that point?
Absolutely. And we would only prefer mother's breast milk. So we have 2 options available for our preterm babies born less than 34 weeks. We use mother's own milk, which is hands down the best choice for the baby because it naturally comes from mom. It hasn't been pasteurized, filtered, and used multiple containers. And so nutritionally, it's a lot richer than donated breast milk, which is our other option.
It's the fresh stuff. It's got to be the best.
Well, milk is also variable. So early on, mom pumps higher protein milk and her fat content because the first few months of life, the baby needs most of their calories from fat for growth. And so milk early on is more nutritious than milk. So we do have a donor milk program, but that milk comes from whenever.
Months out. She's like a wet nurse. She's
like a wet nurse.
Continues to lactate. And It's a different composition.
Mm-hmm. Which we really appreciate all our moms who donate breast milk. And,
bless them.
And I would encourage anybody who has a freezer full of breast milk, please don't hesitate to donate it because that donated milk feeds all kinds of preterm babies across the United States. And it has made a huge impact on the rates of something called necrotizing enterocolitis.
Yeah, tell me, you had mentioned that. We call it necrotizing enterocolitis. So what is NEC?
It is an inflammatory, infectious problem in the gut of preterm babies. And it can range from mild distension to severe bowel necrosis.
So it can die. So part of the bowel can die. And then they need surgery, don't they? Mm-hmm. Then the pediatric surgeon comes in.
And so they, when you develop, the reason why we want to do everything we can to prevent necrotizing enterocolitis, the mortality is high from it in severe forms of NEC. But the morbidity is worse because the number one
chronic illness. It doesn't kill you, but it hurts you.
And you know what the number one morbidity is from NEC?
Please tell me.
It is poor neurodevelopmental outcomes. That gut infection will affect the child for life. They have higher rates of cerebral palsy, higher rates of long-term neurodevelopmental problems. And so we have, in general, we're trying to move away from giving our preterm babies formula to giving them either mother's own milk, which is our first choice, and then donated breast milk as our second choice.
Okay.
And then on top of that, because preterm babies have such high caloric requirements, even mother's own milk won't have enough calories, enough protein, enough calcium, and enough phosphorus to support their preterm baby. So we will use additives to it. Now, depending on the rate of prematurity, there are a couple additives we can use. One of those is something called Prolacta, which is a higher calorie protein, calcium, and phosphorus that is derived from human milk. So this company actually spins down the human milk.
And concentrates the good stuff
from donated breast milk. So again, all those women out there interested in donating their breast milk, you are doing a good thing. You are doing a really good thing. You won't see the results of it, but no, you are helping a lot of people and a lot of babies.
Like donating blood. They split it into different components. You help a lot of people.
Exactly.
Well, this is fascinating. What, do you recall offhand when this concentrated breast milk was available? Because I don't remember that in my training.
So it really has only been for the last few years.
It's recent.
It's recent, and it is very expensive. And due to the expense, some hospitals opt to use something called a human milk fortifier, which is a formula-based product from bovine-based from Similac and Enfamil, and it's very good. We have very good growth on it. And we do switch the babies over to it at 34 weeks when their risk of neck significantly decreases. But it is still considered a very acceptable alternative. And the neck rates from that are very low. About, I'd say 10 years ago, 11 years ago, we switched from using powdered HMF to only using liquid preparations of HMF, which have reduced the rates of infection. And we think that what was happening is that the powder was at risk for getting bacteria in it. And now with the liquid preparations, they're sterile. And so we aren't seeing as much neck because of that. So as a profession, neonatology has done a lot to prevent necrotizing enterocolitis because of all the long-term neurodevelopmental problems, and in particular in our micropreemies.
Micropreemies. So we're going to work our way down to micropreemies. So let's stay with our preterm baby at about 32 weeks. You're getting some nutrition into your patient. You've got an IV somewhere in their body. Sometimes you go through the umbilical cord too. That's a natural way if you can get in there. What else do you have to worry about? So now you've got breathing and nutrition. Are there any special things about the brain you need to worry about or be concerned about?
So typically at about 32 weeks, we are worried less about what we call intraventricular hemorrhage.
Or we call a brain bleed.
A brain bleed. So any baby born over 33 weeks, we don't routinely do a head ultrasound, but beginning with any baby born below 33 weeks, we would get a routine head ultrasound. We don't routinely see head bleeding in them, but we can, depending on what brought them to us. Again, there are certain conditions that moms can't control that put the baby at higher risk for having those head bleeds. And one of those is chorioamnionitis, which you're probably familiar with.
Infection of the membranes and the tissues of the uterus that surround the baby. So those can get infected. I didn't know that and put the infant at higher risk of a brain bleed, an IVH.
A brain bleed or just in general cerebral palsy, even without a brain bleed. The inflammatory markers that the baby is exposed to can put them at risk for that. The good news is most cerebral palsy is more of a tone issue. And so many of these babies with good physical therapy are going to live really long, happy, productive lives.
With full intelligence?
Yes. And you know, I think that's always a little more difficult to extrapolate because they might be doing really good in school. I don't know. Maybe they would have done better if they hadn't had it.
Right.
But we tend to lose a lot of our outcomes in terms of intelligence as the kids get older just because they get lost to studies. A few years ago, somebody went back and looked at children and young adults who had been born prematurely and said, I'm going to compare them to adults their same age who were not born preterm and see how they're doing.
Okay.
And the really amazing part of the study is we found out that they are really on par with so many of their term counterparts. They're entering into relationships. They're going to college. They're working jobs. And so we can't say, oh, your child will be just as smart as if they had been born at term or just as smart if they haven't been exposed to this. We don't really know that. And they might have some problems. But we find it really reassuring that we can tell parents there's a good chance your child is going to have a productive life. They're going to have similar happiness ratings as their term counterparts.
But whatever you can measure, they're awfully close or the same or not statistically different. That's great to know, Michelle. So is there anything else you can do for the brain? Now, when you have a severely premature baby, is there any role in C-section to protect their little head so it doesn't get squeezed on the way out of the birth canal, or is that what are your feelings on that?
I do think the C-sections are a little easier, and it's really nice when the obstetrician is able to deliver them inside their bag. Depending on if they had ruptured or not. Sometimes it's just not possible. I've seen them delivered in their bag, even vaginally, and their skin is so well cared for.
So the bag is called on call. It's that's an old French expression. But when the bag of water comes forward, if it's not broken, that applies the pressure to the cervix and the birth canal and opens it up so the little baby can come out a little easier. Am I reading that correctly?
Yes, that's correct. And what we like about it as neonatologists is they don't experience any bruising. In our really small babies, bruising is a significant problem because first of all, they don't have as much blood circulating because by virtue of their size, they just don't have very much circulating blood. So any blood they lose to bruising is a big deal.
So that's what a bruise is. The reason it's purple is that's blood that has leaked out and infiltrated your tissues here.
It's a hospital.
Now, Michelle is on call, so you have to answer that. That's fine. So for our folks at home, Michelle is actually on call, and she has got a call for a very important thing she needed to take care of. So I believe, to get back into the conversation, we were talking about that little infants have very little blood, and if they bruise during delivery, that blood loss can be significant. So if we can avoid bruising during delivery, that's a good thing. And so now we have a little infant born between 32 and 34 weeks. You've taken care of the breathing, the bowel. Now let's talk about the blood. They don't have very much of it.
That's correct.
And now it's not going through the placenta. It's not there's a lot of blood in the placenta and some in the cord.
So we do the delayed cord clamping. We try really hard to get as much delayed cord clamping as we can in those small babies because if they're breathing, they will suck that blood back from the placenta.
So instead of cutting the cord immediately, you leave it attached to the infant, and blood that's in the placenta and the cord will infuse, and they'll actually suck it back in to a degree, so it's not wasted. So delayed cord clamping. That was full-term. I know that's controversial in term babies now, but preterm, there's no controversy. That's a good thing.
So in term babies, it's less controversial than it was years ago. And I think the original thought is that they wanted to deliver the placenta as quick as they could just because of risk of maternal bleeding. But they found that delayed cord cutting for about 30 to 45 seconds in term babies really didn't pose a risk to the mother. And with a term baby who's crying vigorously, who doesn't have as much blood circulating in the placenta anymore now because the baby's bigger, he or she can pull the blood out pretty quickly with crying because when they cry, they create negative pressure. It's a lower pressure zone compared to the placenta. They suck the blood out. And so we are routinely doing that in term babies now. But in our preterm babies, we have to delay for a minute because they don't create as much negative pressure with crying. And we really need as much blood out of that placenta as we can get just because the ratio is a little different. There's a lot more blood concentrated in the placenta for a preterm baby than there is for a term baby. And they really need every drop. And it's a minute by minute change for a preterm baby. At any minute, they could actually have more blood in the placenta than they do in themselves. And so we'd really like them to pull that blood as much as possible because those babies are going to experience frequent blood draws and often need transfusions just related to frequent blood draws.
Yeah, I know that anemia is a big deal in a premature baby. Now, blood in you and me, mature adults, is being mainly made in our bone marrow.
That's correct.
But in a little preemie, is it coming from the liver or other places?
So they do have a higher percentage of fetal hemoglobin, and that will break down pretty quickly after birth. And so that does contribute to their anemia. It also contributes to jaundice. And so anytime blood isn't circulating, it's breaking down. And that bruising that we talked about earlier also can create more jaundice, which can be more dangerous for the preterm baby because their liver's immature.
So the blood breaks down, it releases this hemoglobin and other hemes and porphyrins and all these things that are kind of toxic, aren't they? So the blood's is it coming from the bone marrow and the liver at that point at around 32 weeks?
No, not at 32 weeks. It's mostly the bone marrow.
So the bone marrow is kicked in by then.
That's correct.
So it's earlier. So blood is in short supply. So if a person has a premature baby, anemia is common and they might need transfusions.
They might need transfusions. Sometimes if they're really sick when they're born, let's say the mother had developed an infection and that's why they were born prematurely, They might need blood. They might need platelets. They might need something called fresh frozen plasma to help with coagulation factors.
All the components of blood.
All the components of blood. And so it really depends on what brought the baby into the world early on anyway.
Boy, that's a lot of blood, a lot of tubes. Michelle, how do you get access to a big vein in one of these babies? I mentioned that you can put a tube in the umbilicus and the umbilical cord vessels, but that's not always available, or they break down and you can't use them. How do you get access to the blood supply of a baby?
Yeah, so most of the time we have to use the umbilical vein and the umbilical artery, and we would really prefer to get rid of those lines by 7 days just because of the risk of infection. But if we have to leave them in earlier, we will. Longer, we will. The other option we have are something called PICC, peripherally inserted central catheters.
So you can get a tube in the central venous. Where's that going? The arm or the groin, or where does it go?
Can go arm, groin, scalp, legs.
You can get a PICC line in the scalp?
That's correct, yeah. We
oh my goodness.
Find a good vein, and we just thread a tiny little catheter all the way down centrally to their superior vena cava.
So near in the chest, where the blood vessel's the biggest. That way you can take blood for testing.
We can't take blood from those. So for most of our blood draws in preterm babies, we do something called capillary sticks, where we warm up their heel.
The heel.
And we squeeze the blood out. Yeah. And it's really uncomfortable. We do know from studies that our preterm babies have altered pain responses. And we think it's related to the amount of capillary sticks. If you've ever stuck your finger for a blood sugar, it hurts. There's a lot of little nerve endings in your fingers and your feet.
Right.
And but the option of having a catheter that can actually draw blood from a vein is next to impossible in our micropreemies.
Right.
So once their umbilical venous lines are gone, we don't have a lot of options for blood draws.
Now, did you say you didn't finish the thought? So do they have higher pain from a heel stick or lower pain after you've been doing it?
They have altered pain. And
the
reason why we say that altered is we worry that they won't respond the same to painful stimuli, and they can experience pain in a different sort of way. So when they fall and hurt themselves, it might hurt out of proportion, or it might hurt under proportion.
I mean later on in life.
Later on in life.
Their perception of pain can be different.
Their perception of pain is altered.
Fascinating. So you can give transfusions, medicines, antibiotics through a PICC line, but you're testing the blood through the heel sticks. I assume you're checking there. You'd mentioned calcium and phosphorus. These are salts, fancy minerals that are crucial. What do you do about those?
So our preterm babies who are born in the what we call the very low birth rate weighing range, which is less than 1,500 grams, are at risk for something called rickets or osteopenia of prematurity. And so we routinely test their blood beginning at a couple weeks of age, their phosphorus levels, phosphorus levels, and their calcium to make sure that they're getting appropriate supplementation. So they need
to grow their bones. Because they're growing very rapidly. Their bones are part of that.
Bones are growing rapidly, and if they don't receive enough calcium, phosphorus, and of course vitamin D to absorb that, they won't lay down bone. They'll start to leach their bones.
Oh my goodness.
And so their bones will become brittle. And so it's really essential that the babies receive adequate nutrition. So one of those things is getting them on enteral feeds fast enough. Because
enteral means in the gut.
In the gut.
Where parenteral means in that PICC line in the vein.
Exactly.
Okay.
So anytime we can get all the feeds in the gut and get them fortified with either a human milk fortifier or Prolacta, or a formula that's appropriate for a preterm baby, we can get them enough calcium, phosphorus, and we add vitamin D to help them absorb things correctly. And that will help protect their bones. We don't really know what their bones will look like when they're elderly, because we just don't have babies that have survived to old age at this point in time.
Yet.
Yeah. So We are doing our best to protect their bones going into childhood and young adulthood now, and hopefully the future, when they're growing old and aging, their bones will be solid and not at higher risk for osteoporosis.
I'm learning so much from you, Michelle. So much has changed. I don't even remember hearing about bones when I was a medical student doing my pediatric rotation. Boy, I'll never forget my NICU. Even as an obstetrical resident, an OBGYN resident, we had to spend weeks in the NICU, and it was what an impressive world you live in. I hadn't even thought about bone. Wow. So, are there any other common problems in these infants at 32 to 34 weeks? Because we're going to go lower now.
Well, really, I think we've covered most of it because so much of it depends on what brought them into the world.
Okay.
Are they sick because there was an infection that brought them into the world? Are they here because mom had preeclampsia?
That's a high blood pressure.
Blood pressure.
And you have to save the mother's life and get the pregnancy over with. There's no treatment for preeclampsia other than delivery.
That's correct. And really because neonatal care is so good, whenever there's any chance that the mother's life is at risk, we're always happy to deliver.
Gotcha. We have to make these really tough decisions. Isn't temperature also important as well? These babies can get cold, can't they?
They can. So babies who are born really small, less than 32 weeks, or 32 weeks and below, I should say, we automatically put them on something called a porter warmer in the delivery room. So in that radiant warmer, as you call them, Ohios.
The Ohio.
I didn't learn that. I just learned that.
With the French fry lights that there was kind of the red, infrared.
They have modernized that a little bit.
It's a little better now.
Yeah, it's a little better. It's still really hot to stand under, but
keeping them the right temperature is real important.
It's really important. So the first thing we do is we turn up the temperature. If you're having a C-section, we turn up the temperature in the room just to make the room warmer. And then we place them on a porter warmer, and we have a plastic wrap the baby's wrapped in. So instead of them being wet with cold air running over them, they're now wet, wrapped in plastic, and it creates essentially a blubber layer. And the porter warmer provides heat from the bottom up, so they have heat coming down on them and heat coming up. And these things help protect them from heat losses via convection and conduction.
Do you still use saran wrap kind of stuff over the table? When I
remember that.
We used to use saran wrap. The baby would be there with all the tubes, and they would literally put saran wrap over it to keep it warm, to keep the wind.
Yeah, they had the big thing of saran wrap, and they would tear it off and wrap the baby in it. No, we actually have a medical grade saran wrap. I'm not really sure that it's any different.
1,000 times more expensive and 1% better.
Yeah. Well, back when I was a resident, we used to do things like just dip pacifiers in sugar packets, and now we buy very expensive Toot Sweet and sugar concentrations. So we do wrap them in saran wrap. Maintaining a baby's temperature is essential, and having a good temperature after delivery significantly impacts the outcome of babies who are born 32 weeks and below.
So, not to put you on the spot, but at around 32 weeks, you said an infant usually weigh like 1,500 grams or 1,000 grams about that?
No, 1,000 grams is technically 28 weeks.
So a baby's around 32. What I want to get to is at around 32 weeks, I think survival numbers are very, very good.
They're high, very high. And
upper 90s?
Absolutely. So we look at survival rates, and all of these have to be taken with a grain of salt because there is a neonatal calculator you can punch these into, are affected by what brought you into the world.
Right. No, one size does not fit all.
Exactly. So at 28 weeks, we look at survival rate around 95%.
At 28 weeks?
Intact survival, yes.
Wow. So at 32 weeks, and it's way upper 90 percentiles.
I would expect babies at 32 weeks to survive, barring a severe infection or complication that would increase their mortality.
Right.
Beyond the typical NICU stuff.
Do you mean 98%, 99%? What are you talking?
Yeah, so we'd have to put it into the calculator, but I would guess the survival is up around 98 to 99%. And the babies that are passing away are probably severely ill or had a congenital anomaly.
Yeah, a problem with for example, their heart or something that was irreparable. So, Michelle, I just want to put a finer point on that. This is just amazing work that you and your colleagues do. You can have a baby that would otherwise probably die and you do this routinely. 32 weeks is probably just a routine case for you. And have a 98, 99% intact survival rate. Intact meaning they got all their marbles and they're running and playing sports and growing up with nobody knows that they were premature. And that's incredible, Michelle. So now let's go into the deep waters. Now we're going to start dealing with the very premature infants. Now you're getting down to, let's go right to below 30 weeks here. We said, world record is somewhere around, 22 weeks and 500 grams. Now you're getting into severe prematurity. Tell me about the whole, somehow condense the problems you're going to face in a severely premature infant.
So the first thing I always talk to parents about, and one of the first things I tell them is, I can tell you all the bad stuff. And I meet them in prenatal consults, and I say, these are all the bad things that can happen.
Before it's born.
Before the baby's born.
Prenatal consults, we say, this baby's coming early, there's a problem, speak to the neonatologist so that they can know what to expect and they can be counseled appropriately. All right, what kind of stuff are you talking to them about?
So I tell them all the bad things. I tell them about the head bleeds. I tell them about the risk of necrotizing enterocolitis, the feeding intolerance, the risk for acquired infections in the NICU because of the central lines. I talk to them about chronic lung disease. I talk to them about patent ductus arteriosus.
All right, so let me explain that. When a fetus is not yet outside the womb and breathing, the heart is bypassing the lungs and has to go through these holes in the heart to keep the circulation going. And when a baby's normally born at full term, takes a breath, the pressures change, and this thing flaps closed.
Exactly.
So it's closed, or this vessel between the aorta and the, I can't believe I remember that.
Yeah, pulmonary artery.
And the pulmonary artery in there, and it tightens up and closes up.
That's right.
Circulation. So if they're born premature, those blood vessels don't close up like they should.
That's correct. So it's a cheater vessel. It's so that the fetus has blood go, because when the baby's in utero, blood is coming to the right side of the heart because it goes up through the umbilical vein. And there, you have to figure out a way to get it over to the left side so it can go to the body.
Okay, the right side of the heart in us is pumping the blood from the body through the lungs.
Exactly.
Then it comes back to the heart to the left side to go to the body.
Yep.
So if you've got your blood coming from the placenta through the umbilical cord, you don't want it all going through the lungs. It needs to go straight to the body. So then you're going through these openings. Okay.
And the lungs don't need the blood because you're not using your lungs in utero. So the lungs just need a little bit of blood in utero to grow.
Like any other tissue.
Yeah. So you have all this oxygenated blood coming up through the umbilical vein. And that oxygenated blood needs to figure out how to get over to the left side of the body. And so it does that two ways. It does it, one, through what's called a foraminovalle. And after you're born, it's called a patent foraminovalle. And it exists between the right and left atrium. And so a good majority of the blood that comes back from the umbilical vein is going to go over from the right atrium to the left atrium through that foraminovalle.
Okay.
And then some of that blood, the rest of that oxygenated blood from that right atrium, will be pumped down to the right ventricle. And again, this is rich oxygenated blood that just came from the placenta. And that then goes out the pulmonary artery towards the lungs. But the lungs don't need it all. And so it gets shifted over through the ductus arteriosus, which after birth is called a patent ductus arteriosus.
If it stays open.
If it stays open. And in term babies, there are physiologic changes that make it possible to close that vessel. As soon as that baby takes a nice big breath of air that's oxygen rich, and that pulmonary lungs, it just relaxes, all the physiologic setups allow that to close off. The problem is in preterm babies, physiologically is not designed to close because it was supposed to
ready.
stay. It's not ready. It was supposed to stay open for a few more months or 10 more weeks or 12 more weeks.
Sure.
And so oftentimes what happens if the baby has a large ductus arteriosus, we need to give medication to close it. We use ibuprofen. Good old ibuprofen.
Really?
Good old
did
ibuprofen.
It used to be aspirin or caffeine, or what did you used to use?
Indocin is still available. We do use Indocin. We use ibuprofen, and we also can use Tylenol.
I'll be darned.
But sometimes they still don't close. And so years ago, the surgeon would come in, and they'd have to ligate those PDAs.
That's a chest surgery.
And that's a big deal.
It's a big deal.
It's a big deal.
I saw a patient 2 days ago with the chest scar, all very pale, well healed from
having their PDA ligated.
Yeah.
Well, modern technology is doing away with that because now the cardiologist can do this via transcatheter through a vessel in the leg.
So you can thread a little tube in somewhere, maybe going through the groin, they can thread in a tube. And how do they block or occlude that PDA?
A little transcatheter device. And they do it as low as 750 grams now in babies.
Oh, my goodness.
They're trying to get down to 500 grams.
So the patient is this big.
Yes.
And they can thread this tiny little tube and close that PDA.
That's correct.
Patent ductus arteriosus. Amazing.
And as a matter of fact, some babies will have it, but clinically they'll be stable from it. And so we might keep them until they're 32, 33 weeks. And then if it's not closing off and they're starting to show some signs of heart failure, we might send them to have it done a little later. There's a lot of variability in the treatment of these vessels.
Okay. So
that's one of the things I talk to parents about. So I have this long list of things I tell parents. But one of the things I always tell them at the end is I can tell you all the horrible stuff, but what I can't make you see right now are all the good outcomes that all the healthy children that I have seen get through extreme prematurity. And I follow these kids until they're 3, 5 years old sometimes in my developmental clinic. And I have a very positive outlook on our micro preterm babies because I see them do so well long term.
So when these babies go home, you're not done with them. You do follow up for years afterwards. I didn't know that either, Michelle. Tell me about that. What do you do there?
So we, here at Boone, we bring them back to a developmental clinic, and we have a physical therapist and an occupational therapist who performs a Bailey exam. And based on the Bailey, we compare it to, the Bailey was designed to compare term counterparts and look for developmental disabilities. So if at 2 months you're supposed to put your hands to your mouth, every baby can do that. So they have set developmental skills that they test that everybody at a term gestation should be meeting.
Okay.
And we then use that to compare our preterm babies. So
and do you have to adjust it for when they normal for their with their ideal birth day?
Yes. So we use what we call the adjusted gestational age. And so if they were born at 25 weeks, we take them back 15 weeks and we subtract that and look at what they're doing developmentally. And what's so amazing is I often find that most of these kids are somewhere between their actual age and their adjusted age. So they're kind of doing really good. They're trying to make up for what they missed out on in growth in utero.
I'll share a personal story, and that this is not personal or private. This couple, they're very public about their situation. I've been here 17 years, and this doesn't happen very often. But I had a set of quadruplets my first year here, who your colleagues took care of, and they just turned 16, and they're all in sports, and they're all good looking, and they're all smart. I know they were born at 29 weeks, which is, you can do the math, 11 weeks early, and I know they received, a couple $1 million of intensive care, and they're doing just fantastic. Your current colleague may have been here to help in their care. So it's very, very gratifying to see the work that you do. Now, let's say you have a severely premature infant. Now, you have a very good NICU here. You're obviously, you and your colleague Tim are very, very experienced. Is there a point where a severely premature infant should go to one of these special medical centers that has lots of resources? They've got the pediatric cardiologist and the pediatric surgeon, and is there a point when you say, hey, I need to get out a helicopter or an ambulance and send them to a regional center? Tell me about that.
Absolutely. So most of the babies that I end up transferring, who are usually term babies who need a subspecialty that I don't have here, or they are having breathing problems.
So full term, but they have an abnormal heart, or what other things would you see other than heart? I know we have a lot of heart issues here.
Persistent pulmonary hypertension would be something that should be cared for mostly in Kansas City or St. Louis, just because they're level 4 NICUs, and we only have level 3 NICUs here. And level 4 is
level 4 is the highest.
Level 4 is the highest, and they have what we call ECMO capabilities.
ECMO. All right, let's tell people about ECMO. Normally, the blood from the baby's going to the placenta. There, it interfaces with the mother's blood. Mm-hmm. Carbon dioxide, waste goes out. Exactly. Oxygen comes back, and it comes back oxygenated. Mm-hmm. If this little severely premature baby has not undeveloped or poorly developed lungs, it can't get oxygen. So how can you essentially be a lung for one of these little babies?
So our preterm babies won't qualify for ECMO. So ECMO is for babies who are 34 weeks and greater than 2 kilograms who have pulmonary hypertension or a heart defect.
So ECMO is not for less than 34 weeks?
Yes, that's correct.
I didn't know that either. So what does ECMO mean?
Extracorporeal membrane oxygenation, and it requires a special team to take care of those babies in an ECMO center.
And a special machine.
And a special machine.
And the team that goes with it. So essentially you're bypassing the lungs. I think it goes in the carotid artery.
Yes.
So it's one of the biggest vessels. Blood comes out of the baby, gets oxygenated in an artificial lung, and goes back in.
Exactly. And that's used for babies who have a congenital anomaly or just primary pulmonary hypertension.
Which means high blood pressure of the lungs. So the blood is just not getting through the lungs.
Exactly. They're trying to stay in that fetal circulation I talked about previously. And so instead of those lungs relaxing like they're supposed to, the pressures stay high. And so blood gets shunted away from the lungs like it would in utero. But the problem is they're not in utero anymore. They're not hooked to that placenta, and so they need to use their lungs. And so we bridge them with ECMO until their pulmonary vasculature relaxes and they're able to use their lungs.
So you can bridge past that, and that problem can be treated with medicines. Absolutely. And tincture of time. Mm-hmm. Time is a big deal.
So with our micro preterm babies, the reason to transfer them would be, like you said, for surgery. So if a baby were to develop necrotizing enterocolitis and need surgery, then we would send them to a surgery center. If they were to need a PDA ligation, we would send them to, again, a center that had the cardiologist who was trained to do those transcatheter ligations.
And they're busy. They do this all the time.
They do it all the time.
That's been a recurrent theme here. Every specialty we've interviewed, doctors of many, many specialties, and that's a recurring theme because somebody does it all the time.
Yep.
So I have some very poignant stories during my training. I told you about the quads. I told you about having to deliver, usually suddenly out of the blue, a severely premature infant. Do you have any special stories, Michelle, that keep you going, that warm your heart and keep you enthusiastic? Or we use the term miracle, I think maybe a little too much. I don't think it's ever wrong to use the term miracle when we talk about our babies that come out of the NICU, because they really are miracles. They're such a small percentage of the population, and they're here because of modern medicine. Yeah, now I would call it I
a modern medicine miracle.
I prefer to call it miraculous.
Okay,
it's miracle-like.
Yes,
but that you didn't get here by some miracle.
And it really takes a team. I can't give enough credit to the nursing staff in the NICU, because
tell me more.
The nurses in the NICU are the ones who care for the babies. They are hands on the babies. They're the ones that are in with them all the time. And it is well documented that what makes a great NICU is having nurses that know how to take care of babies. And that's an across the board thing. So, we're really smart. We went to school a long time. We studied a lot. We do certain procedures.
As doctors.
As doctors, we give orders. But at the end of the day, our nurses are the ones who make the difference. And they're there at the bedside with the families. Our parents are always grieving. They're grieving the loss of a healthy baby.
It's so stressful for parents.
It's incredibly stressful. And they're grieving the loss of having that baby with them, just like their friend. And it really takes small things. Maybe they are in a restaurant and they see somebody with a baby.
Yes, and it triggers them, yeah.
It triggers them. Like, I'm here because my baby's in the NICU. I don't have my baby with me.
Oh, it's just so difficult.
Well, and I always tell moms, we're asking you to do something that isn't natural.
Yes.
You have, for millions of years, or probably not millions, but a long time.
Many millennia.
Many millennia.
A
long time. The human race has survived because women keep their babies with them.
Yes.
Women keep their babies close to them. They feed them. They don't leave them out in a field. They don't leave them at Walmart. Yeah. They don't come home and say, I forgot something.
The mama bear protects them.
The mama bear protects them. And, you watch any mom walk through the grocery store with her baby. She looks at that baby 20 times every minute, even though nobody's even walked by. She's checking on that baby, checking, because that's her sense of protecting her baby.
Yeah.
And all of a sudden, we take your baby and say, this is the best thing for them. And after they're born, no matter how you slice it and dice it, the moms know the baby's preterm. The moms know they need to be in the NICU. But having that baby away from them is just so terribly difficult. And it just really is amazing to watch how these parents work through this. It's so difficult for them. And our nurses do a great job helping them. And I don't know, I'm really impressed that they're able to do what they do as parents.
A lot of stress in the NICU. I occasionally have a patient who we help them conceive, and there's the due date, and then I hear, sometimes I'll get a call from the husband, my wife's in the NICU, it came early.
Oh, yeah.
Because I have women who were born with an abnormal uterus and tumors and stuff, and I've done my best to fix it, but I've made it better, but not perfect, and they get into trouble. So I do go over to the NICU from time to time, and I've experienced put on the gown and know the stress and how difficult that is. Well, Michelle, we could talk forever about this subject, but I just want to say I'm so grateful for you and Tim O'Connor to have you as colleagues here at Boone Hospital. I know you do fantastic work.
And I just want to add to that,
Please.
My new partner, Silpa Paravalli. She's been a great addition.
Oh, great to know.
Yeah, Tim O'Connor actually has retired to just doing well baby. Dr. Paravalli is one of our new neonatologists, and she comes to us from Tennessee. She's got great training, great personality, and we're so happy to have her on our team.
Well, that's great to know, Michelle. So it's comforting to know that your field continues to improve. The world record keeps inching downwards. Your ability to get these tiny little patients through these tough times and onto happy, healthy, productive lives is just wonderful, amazing, and sometimes certainly miraculous. So thank you so much, Michelle. I've learned so much from you today, and I appreciate you taking time to speak with us today.
Absolutely. And if anybody ever has questions about the NICU, we're always happy to answer. If there's any concerns or going to have a preterm baby, their obstetrician will put them in touch with the neonatologist pretty quickly.
And you're happy to speak with them and counsel them.
Well, and I like to get to know the families because we spend so much time together. At the end of the day, these parents spend a lot of time in the NICU at the bedside, and it's an opportunity for me to get to know them because they have to know who we are. We take care of the most precious thing they have.
Yeah, that's really sweet. Well, thank you so much, Michelle.
You're welcome.